Today's topic of discussion is endometrial hyperplasia. But before going into detail of that, the normal endometrial thickness is around 8 to 11 millimeter. This is taken as an acceptable range. Now, the risk of endometrial carcinoma is around 7% if the thickness is increased from 11 millimeter, but it is less than 0.002% if the thickness is less than 11 millimeter. As I discussed with you, the normal thickness of or the acceptable range of thickness of endometrium is 11 to 14 millimeter. It is seen in various studies that thickness of endometrium greater than 14 millimeter is associated with atypical endometrial hyperplasia or endometrial hyperplasia or complex endometrial hyperplasia with cytological atypia. Under 14 millimeter thickness, the risk of endometrial hyperplasia is low, and below 14 millimeter of thickness, the risk of endometrial carcinoma was found to be 0.06%. Now, dear colleagues, we are going to discuss a topic which is endometrial hyperplasia. Endometrial hyperplasia is important because it is responsible for abnormal endometrial bleeding or intrauterine bleeding. It is defined as proliferation of the endometrial glands relative to stroma, which results in the increased gland-to-stroma ratio when compared to the normal proliferative endometrium. Now, I explain that once there is a proliferative endometrium, there is proliferation of the stroma, there is proliferation of the endometrial glands. The endometrial glands are tubular in shape. But in case of endometrial hyperplasia, the increase is in the favor of glandular proliferation as compared to stroma. The number of glands as compared to the proliferation of the stroma is in the favor of the glands. Endometrial hyperplasia is associated with prolonged estrogen stimulation by the estrogen hormone. Endometrial hyperplasia is associated with prolonged estrogen stimulation of the endometrium, which may be due to exogenous source or endogenous source, but it is associated with anovulatory cycles. There are many conditions which are associated with endometrial hyperplasia, and that include obesity, menopause, polycystic ovarian disease, granulosa cell tumor of the ovary, and that granulosa cell tumor of the ovary which is functional. The functional tumor of the ovaries like granulosa cell tumor which produced estrogen hormone. Besides this, there is excessive cortical function which leads to endometrial hyperplasia. Similarly, prolonged administration of estrogen substances as a part of replacement therapy, they are also responsible for endometrial hyperplasia. The genetic alteration which is commonly found in a significant number of endometrial hyperplasia is inactivation of PTEN tumor suppressor gene, which is located on Q arm of chromosome number 10. PTEN is responsible for encoding a dual specificity phosphatase capable of dysphosphorylating both lipid and protein molecules. But when PTEN is inactive, AKT phosphorylation is enhanced, which stimulates protein synthesis, cell proliferation, and at the same time inhibits apoptosis. Mutation in PTEN is seen in more than 20% of hyperplasia, both with or without atypia, and in 30 to 80% of the endometrial carcinoma. Gordon syndrome is caused by germline mutation in PTEN mutation, where high incidence of endometrial carcinoma is recorded. Regarding Gordon syndrome, it is an autosomal dominant inherited condition which is characterized by benign overgrowths called hematomas, as well as increased lifetime risk of breast, thyroid, uterine, and other organ cancers. Now, coming back to loss of PTEN, which results in the activation of AKT, which is also called protein kinase B, actively lead to phosphorylation of estrogen receptor in a ligand-independent manner, which means that loss of function of PTEN function may activate pathways which are normally activated by the estrogens. Now we'll briefly discuss classification and morphological features of various types of endometrial hyperplasia. First, simple endometrial hyperplasia without atypia, which was also known as cystic or mild endometrial hyperplasia. In these conditions, the glands are of variable sizes, their shapes are irregular, and some of these glands show cystic dilatation. The epithelial growth pattern and cytological features are similar to those of proliferative endometrium, although mitosis are not very prominent. Such type of endometrial hyperplasia, only 1% of them, they progress to adenocarcinoma. Many glands in this condition may undergo cystic atrophy when estrogen stimulation is withdrawn. The next type is simple hyperplasia with atypia. It is an uncommon type because as far as the structure is concerned, the glands are simple. That when I say the glands are simple, it means they do not show any budding or they do not show any marked variation in size and shape. But there is cytological atypia within the glandular epithelial cells. And when we say cytological atypia, it means the nuclei are vesicular, the nuclei have prominent nucleoli, they lose their normal arrangement to the basement membrane, and there is loss of polarity. 8% of such lesions, they progress to endometrial carcinoma. The other type is complex endometrial hyperplasia without atypia. In this condition, there is increase in the number and size of endometrial glands, marked gland crowding so that the glands are lying back to back against each other. The glands show a branching pattern, with the result there is a very little intervening stroma and there are also abundant mitotic figures. These glands remain distinct, non-confluent, and their lining epithelium remain cytologically normal. This class of lesions, they progress to endometrial carcinoma in 3% of cases, and the incidence is lower than simple hyperplasia with atypia. Now, one thing you must appreciate that it is the cytological atypia which is more important rather than the architectural pattern of the glands. The other type is complex endometrial hyperplasia with atypia. When I say that complex endometrial hyperplasia, it means the glands are increased in number and their lining epithelial show atypical changes. Sometimes it is very difficult to differentiate with well-differentiated endometrioid carcinoma. With the result, the accurate distinction between complex endometrial hyperplasia with atypia and adenocarcinoma of the endometrium may be possible only on hysterectomy specimen. There is a study in which females with complex endometrial hyperplasia with atypia were treated with progestin therapy alone. 50% had persistent disease, 25% reoccurred, and 25% progressed to carcinoma. Complex hyperplasia with atypia is managed with hysterectomy, or in young women, a trial of progestin therapy is given and with a close follow-up. Now in the photograph, you can well see that the endometrial glands with simple hyperplasia and without any cytological atypia. The dilatation is more and it's almost cystically dilated gland. Now the next photograph, you can well appreciate that it is a complex hyperplasia. Complex hyperplasia means there is crowding of the glands. The glands, they have show variation in shape, and there is budding coming out of these glands, and but there is no atypia which is shown here. Then this photograph shows that the glands are complex, and there is complex hyperplasia. They are lying back to back against each other with very little stroma in between them, and there is presence of atypia